pleasure to introduce our speaker for this evening, Lynn Anderson. Lynn is the CEO of Billings Life Australia and has been a Billings ovulation method teacher and trainer for over 20 years. Lynn has extensive experience in teaching women from a diverse range of backgrounds, as well as training teachers in Australia and around the world. Lynn has also had the privilege of working with the founders of the Billings ovulation method, Drs. John and Evelyn Billings, and gained much valuable experience from them during that time. So Lynn, I'll hand over to you now.
Thanks very much, Rachel. As Rachel said, welcome everybody. It's a real pleasure to be here tonight with you all, and to actually be able to give you some insights into one of the things that charting your fertility can help you with, and that's tracking your fertility, which also means tracking your general health. So just as a bit of an introduction, very few of us realise that the same hormones that are involved in our fertility are also involved in other aspects of our health. And there are many facets of our health in which they are involved, but a couple that might be of interest are the way that our bone density is affected. Now, for women of a certain age, as we reach menopause, most of us know these days that our bone density relies on being able to absorb calcium. And estrogen is essential in that process. As we reach menopause and we stop ovulating, we don't produce the same levels of estrogen as when we're younger. And because of that, we don't absorb calcium as well. And that's basically why osteoporosis, in most cases, tends to be an illness of older men and women, particularly older women, because unless we've stored up enough calcium early in our lives, we stop being able to absorb it. So we need to be very aware and very proactive about making sure that our bone health is good. That's just one area where estrogen is essential. The other one that's rather interesting is at puberty, our brain goes through a rewiring process. There are several different points in our life where this happens. The brain tends to reassess itself, and the synapses and the neural pathways go through an evaluation where those pathways that aren't used a great deal tend to be pruned away, and those that are the strongest tend to be reinforced. So you could say it's the use it or lose it principle. If you're particularly good at a language, then those pathways will be strengthened. But if you don't learn a second language, then it becomes much harder the older you get. And there's a school of thought that this neural pruning that goes on at adolescence is not triggered by, but the feeling is that estrogen in young girls and testosterone in young boys is involved in this process. It's that increase in those hormones at puberty, perhaps, that are influencing this pruning. So they're just a couple of examples of how other areas of health are affected by what we could broadly term our sex hormones. So what I'd like to do now is share my screen with you and just go through a little presentation that gives you a bit more of an idea about, pardon me for a moment, I'll just share my screen with you first. A little bit more of an idea about what's involved in tracking your fertility. Here we go. So for those of you who don't know very much about the Billings ovulation method, just by way of introduction, it's a natural method of fertility regulation that was devised by a Dr. John Billings, hence the name, here in Melbourne. John was helping a friend at the time who was interested in finding if there was a natural way that women could monitor their cycles for family planning reasons. And so John said he'd give 6 months to the work, and 60 years later, he was still involved. And as a result of all of that work, we have the Billings ovulation method. And the Billings method is a natural way to postpone pregnancy, to achieve pregnancy, or to monitor reproductive health and well-being. And it's the third of these points that we're going to focus on tonight, the monitoring reproductive health and well-being. So the Billings method's relatively easy to learn, it's simple to use, it's reliable, and we can talk about that a little bit later if you'd like. There are no drugs or devices, and that's one of the main benefits, because as a result of that, there are no side effects. So you don't have to worry about chemicals, you don't have to worry about whether a device is going to work or not. You're just tuning into your own body and to the information that your body's giving you. So let's look at what happens in a cycle. So Billings teachers talk about the phases of the cycle. There are 4 basic phases. The first is menstruation. We all know about that. The second is a time of infertility that occurs usually after the bleed and before fertility begins. It's a varying length of time, but there's this few days of infertility here. The third phase is fertility, which extends a couple of days past the peak of fertility. And then the fourth part of the cycle is what we call the luteal phase, which is again a longer time of infertility until the next bleed. Now, if we look at these individually, menstruation, we say, starts with the first day of the full flow of bleeding, and that marks the beginning of a new cycle. But the thing we should understand here is that this bleed actually has nothing to do with the cycle that's starting. This bleed is the very last event in the previous cycle. This bleeding is a result of the previous ovulation not resulting in a pregnancy. So there was a new lining established at the time of the previous ovulation in case a pregnancy resulted, and when the body realises there is no pregnancy, that lining is shed. But just as that happens, the new cycle starts. And one of the main reasons we say the first day of bleeding is the first day of the new cycle is because it's a day that every woman can identify very, very easily. We don't have to worry about, is it the right day or isn't it? We know the first day of bleeding no matter where we are or what we're doing. The second phase of the cycle is this infertility straight after the bleed. Now, the length of this particular cycle, or any cycle, is actually determined by these few days of fertility. During these days of fertility, the cervix is producing a very thick, dense mucus that actually closes the opening of the cervix. It actually seals it. The reason is that it has an antibacterial quality to it. So it keeps out any infection that might get into those delicate reproductive organs. But at the same time, it's so dense that any sperm that are deposited in the vagina can't break through that mucus. So they're kept in the vagina, and in that environment, they become incapacitated very, very quickly and unable to cause fertilization. So this is a time that in Billings speak we call the basic infertile pattern. Basic because all of our hormones that are involved in fertility, estrogen, progesterone, luteinizing hormone and follicle stimulating hormone are all at the lowest levels they will be in the cycle. So they're all at their base levels. And because of that, we get this distinctive pattern. This pattern only applies to this pre-ovulatory window of infertility. This is the only time in the cycle it occurs. And it's characterized by being an unchanging pattern. Whatever the woman's symptoms are, and we ask her to record any discharge that she sees and what sensation she feels as she just walks around going about her normal daily activities. But whatever the symptoms are that she notices, it's an unchanging pattern. Now, it may be an unchanging pattern of complete dryness. In other words, she doesn't see any discharge, she doesn't feel any sensation. For some women, they're never completely dry, so it's just an unchanging discharge, which is the same day after day after day. The characteristics don't change, the sensation doesn't change. It's a static pattern. And in an average length cycle, which we say can be up to 35 days long, you'll only have one pattern. You'll have either the pattern of dryness or you'll have the pattern of unchanging discharge, one or the other. Now, as we said, the basic infertile pattern, or the length of the basic infertile pattern, determines the length of the cycle, because in some cases that infertility may last for a few days, or it may last for even weeks or months. Perfect example is in the case of a breastfeeding woman. Some women won't get any signs of fertility for months and months and months because they're in a different hormonal pattern because of the breastfeeding situation, and they will have a static pattern for months. On the other hand, cycles that are short may have very few days or even no days of basic infertile pattern. In fact, fertility can even start while the woman is still bleeding. She won't know that because the bleeding will hide the evidence that there's mucus there or that her pattern has changed. Now, in this situation, the cycle would have to be very short, and I'm talking here something like 21, 22 days, which is unusual, but I have seen women who have these type of cycles. They never have any basic infertile pattern after the bleed. They go from bleeding straight into fertility. So this is a very good reason to understand why you shouldn't assume that just because you're bleeding, you're infertile. It might not happen very often, but it might happen occasionally. Okay, so the next phase of the cycle is the fertile phase. And this phase is characterized by a changing pattern where the sensations gradually become progressively more wet and lubricative until the woman feels a slipperiness, a slickness at the vulva as she walks around. And the last day she notices this sensation is what we call the peak day. This is the day in the cycle that's most likely to lead to a pregnancy if intercourse occurs. So as we said, the peak day is the last day of the slippery sensation, and it's usually the day of ovulation. Not always, but usually. In some cycles, ovulation can be delayed for up to 48 hours. 24 hours is not uncommon. 48 hours is less likely, but we have seen it happen. So once the woman can identify the peak day, she knows that ovulation will occur on either that day or the 2 days following. If ovulation occurs on the second day past the peak, then the egg can live for up to 24 hours. So it's possible that the egg might still be alive and viable on the third day past the peak. But by the end of the third day after the peak, that cervix, which has been gradually closing over again, is completely occluded by that mucus plug, and sperm can't enter. But until that time, there may still be channels of mucus which will facilitate sperm survival and transport. So it's really important that we understand that those 3 days following the peak day are also potentially fertile, although less likely to lead to a pregnancy the further away from the peak day that they are. So the extent of our fertile phase goes from the first day where the woman notices a change from her BIP until the 3rd day past the peak. And that can be a variable number of days. And the last part of the cycle is post-ovulatory infertility. This is what we call the luteal phase. So it occurs after ovulation, and by this stage we know that the egg is dead, ovulation's already occurred, and it can't occur again in this cycle. Once ovulation occurs, there's a very definite change in the hormonal system that won't allow another ovulation to occur in the same cycle. We know that once the woman ovulates, her next menstrual bleed should occur about 2 weeks later, anywhere between 11 and 16 days after the peak day. The woman should bleed if she's not pregnant. And for all of this time, that cervix is tightly closed with that plug of mucus. Sometimes a woman can experience a change from her basic infertile pattern, but that change doesn't progress the way it normally does. It doesn't progress to that slippery sensation where she can identify a peak. She simply has a couple of days of something different, and it might even be accompanied by a little bit of bleeding or spotting on or around the same time. And this is just telling us that this has been an attempt at ovulation here. The process has begun, but it's never gone to the full extent of causing ovulation. Something has caused that process to be disrupted. Now, that may be stress, it may be illness, whatever it is, it's not totally uncommon. In some situations, it can be a sign that there's some sort of pathology, but in some situations, again, such as breastfeeding when a woman's fertility is returning, or in a perimenopausal woman whose fertility is beginning to wane, she will have attempts at ovulation that don't succeed. And then all of a sudden later she might have one that does, but she might have 3 or 4 that don't succeed for every one that does succeed. So this sort of a situation would be something that a woman in perimenopause might see quite commonly. And what will happen is that she'll get this couple of days of something different, but then she'll see her BIP return. And later on in the cycle, she may well progress to a normal, healthy ovulation. Now, it doesn't matter if this happens. This is okay. This doesn't mean that you can't use the Billings method. You can, because the Billings method adapts to whatever the cycle length is. And the rules of the method cover situations exactly like this. And what we're looking at is to say, well, is this normal or not? And to do that, we have to know the life stage of the woman. Is this something we expect to see in her life stage or not? As I said, if she's a 48-year-old woman, we may well expect to see this occasionally. If she's a breastfeeding woman and she's starting to wean, yes, we would expect to see it. If she's a 25-year-old who's never been on the pill, no reason why she should be having these cycles, then we'd be saying, hang on, this is not right. She's a healthy young woman. She should be ovulating regularly. So I'm just wondering at this stage whether there are any questions anybody wants to ask. Have we got any questions coming through, Rachel?
Yes, there has been. So I'll just, okay. So someone's asked, would you have any information as to why period blood would be quite smelly, like an off smell, not the normal blood smell? This relates to a 19-year-old virgin, no tampon use, no contraceptive use.
No, I wouldn't, but it certainly doesn't sound right, does it? Any sort of odour that's offensive needs investigation. Whether it's an offensive discharge, whether it's bleeding, I really think that needs to be investigated, because it really shouldn't be that way. I'd be a little bit concerned about that. I've never had that experience. I've never taught anybody in that situation, but certainly I'd be a bit concerned about it, I think.
Okay. There was also another question. How many cycles do I have to chart before I can use the method and start having intercourse?
Good question. You only have to chart for 2 weeks. Now, what we do in the first 2 weeks of charting is, the reason we need 2 weeks of charting is that we need to get a baseline for you. So we would need to determine what your basic infertile pattern is, and we need 2 weeks of charting in order to do that. So you would chart for 2 weeks, and during that 2 weeks, we ask you to abstain from intercourse or any genital contact, because we can't be sure what stage of your cycle you're in at that point, and we don't want to be guessing, because that's going to have the likelihood perhaps that it might be inaccurate. We want to deal with facts. So we ask you to chart for 2 weeks and to abstain, because perhaps there's a risk of pregnancy, but also because acts of intercourse during this time when you're inexperienced are going to interfere with your own observations of your symptoms. So once you've got 2 weeks of charting, you come back and see your teacher, and then your teacher will discuss that charting with you, and you'll come to a consensus about what your pattern of infertility is. At that point, your teacher will tell you what to do for the next 2 weeks until your next follow-up. So once you know what your basic infertile pattern is, you can start applying the rules. Without your basic infertile pattern, you've got no, you're like a cork bobbing in the ocean. You've got no point of reference. But your BIP, your basic infertile pattern, is your point of reference. If you see that, you can use early day rule 2 and start having intercourse. If you don't see it, then you have to assume you're in the fertile phase of your cycle. So you really only have to abstain for 2 weeks, and then you learn as you continue to chart and as you use the method. And you just have to think about, what do I have to do in the next 2 weeks? Because you're going to be following up with your teacher every 2 weeks. And in each session, you're building up that chart and you're building up your knowledge. So you don't have to wait very long at all. It's not like having a theoretical classroom situation where you study it and then you go off and you use it. You're using it with the assistance of a teacher and learning as you go.
Lynn, there's just one other one before we go on. What if I don't have the sensations you are talking about? Can I still use the Billings method?
Okay, that's another good question. And again, it's one of these questions that the broad answer is yes, you can. Because what we're looking for when we look at a chart is patterns, and the patterns tell us what's going on. So if you have absolutely no sensation, in other words, you're seeing the same thing day after day after day after day, and nothing's changing, that's infertility. And you can use the method because you know it's infertility. You can apply the rules. You're having intercourse according to the rules. That's not a problem. The problem occurs when, as I said before, you're a young, healthy 25-year-old woman and you're not having any symptoms. That's abnormal at that time of your life. If you're a breastfeeding woman and you're seeing the same thing day after day after day after day, at that stage of your life, it's not that uncommon. If you're a menopausal woman and you're seeing the same thing day after day, That's what we would expect. So it's not really I can't give you a black and white answer. I can only say it depends on where you are in your life cycle as to whether or not that would be acceptable as just a normal part of where you are, or whether we'd be saying, please go and see a doctor because this isn't normal for a woman like you. But in all of those circumstances, you can use the method because your body will tell you the state of your fertility, whether it's absent or whether it's present.
Excellent.
Okay. Perhaps I'll move on to the next part of the presentation because that might raise some more questions for people too. So what we've been looking at is just a diagram of a chart, but this is a real chart. So this is telling this woman exactly the symptoms of her fertility. And we can easily see those 4 stages of the cycle here. We can easily see menstruation here, days 1 to 6. We can see that this woman's basic infertile pattern is absolute dryness. She doesn't, I beg your pardon, go back. She doesn't see anything. She doesn't feel anything. She just says, I feel dry. I don't feel anything. And I don't see any discharge at all. So that's her basic infertile pattern. Then she has a fertile phase. Her symptoms change. This woman describes it as feeling damp and seeing something opaque. And you can see the progressive nature of these symptoms here. She's feeling damp and sees something opaque for a couple of days. Then the sensation progresses to wet and she sees some cloudy discharge. Wet again, cloudy, and this time there's a stringy nature to the discharge. Then she feels slippery and sees these clear strings of mucus. Again, slippery and clear. And then the last day of slippery, she doesn't see anything at all. She just feels slippery. And then she has this change back to dryness. So at this point, on day 19, this woman can say, well, yesterday was my last day of slippery, so this becomes her peak day. And then she can calculate when her fertility ends because she knows she just has to wait for 3 more days till the end of the 3rd day past the peak. So her fertile phase starts here on day 12 and ends on day 21. There's her fertile phase. And then the rest of the cycle here is infertile because that plug has reformed in the cervix. There can't be any more ovulations. She's already seen it happen. And so now she's just waiting for that next menstrual bleed to come. So we ask women to record their sensation every day, record the strongest sensation they notice every day, and to describe any discharge just using a couple of words. Just the simplest of descriptions is enough. And we ask women to use their own words. We don't give you a list of things to choose from, because what happens if there's nothing on that list that you think expresses what you felt? If you use your own words, you're more likely to express things correctly in a way that you understand, and you're more likely to remember what you mean by what you've written, because it's important that you can explain that to your teacher when she's trying to be objective about your chart. Every woman's chart is subjective to her, but the skill of a teacher is learning how to learn what each woman means by what she writes on her chart. So that's a typical chart, and that's the way a chart really should look. But what happens when it doesn't look that way? So here's another chart. This lady's name is Sylvia. And we can still see some phases of the cycle here. We can still see menstruation here. Now, this woman is using yellow stamps here, and that's because she has a basic infertile pattern of discharge. We use the green stamp when she's completely dry. But here she's saying, well, I feel dry, but every day I just see the same little bit of mucus day after day after day. So this is a basic infertile pattern of discharge. Second phase of the cycle. She has a change to sticky cloudy. Next day it's wet and clear, wet and clear. She sees wet and slippery, no sensation on that day, just very wet and slippery. slippery on day 16, and then a very distinct change. So correctly, she's marked a peak on day 16 and counted the 1, 2, 3. So her fertile phase has run from day 12 through to day 19. There's the third phase of her cycle. But what happens then? She's got a very short time here between the peak and the next bleed. It's only 10 days. The length of the luteal phase should be a minimum of 11 days and a maximum of 16 days after the peak. And this is only 10. So that would raise some concerns for a Billings teacher who was looking at this. And that usually happens because there's something wrong here with the mechanism of ovulation. We don't know exactly what, but the hormones that prevent the bleeding for 2 weeks are produced in the ovary once the egg has been released. They come from the corpus luteum. And if it's a poor ovulation, you'll get insufficient levels of hormones. And that's often why the woman bleeds early, so she has a short luteal phase. But the second thing that's worrying here is all of this spotting. 5 days of spotting is not normal. Again, it's probably hormone related, but if we can fix the quality of the ovulation, then it will likely fix this problem as well. And we don't know what's causing the problem with ovulation. It could be the woman's thyroid. It could be a problem with the pituitary, both of which are involved in the production of hormones and the release of hormones. So if we don't look at those things, we won't know if there's an underlying problem, whereas this bleeding is really telling us this needs investigation. And we don't know what we might find, but it might be something that improves her general health, as well as simply straightening out her cycles. Now, in this sort of situation, this woman would find it difficult to become pregnant. A short luteal phase usually always means that no matter how the woman ovulates, no matter how, whether she has intercourse at all the right time, she's unlikely to become pregnant with a deficient or a short luteal phase. So that's something that needs looking into. Let's have a look at Hedi now. Hedi is a 33-year-old woman and she wants to achieve. She has been using the pill and she's recently ceased 3 months ago, and she started to chart and recognised a change from her BIP of dry on day 10. So here's her chart. So again, we can see those phases of the cycle, menstruation here, BIP, completely dry, the beginning of her fertile phase. So she goes from dry with a little bit of thick to wet with thick and oozing mucus, to wet with thick and opaque mucus, to wet with thick, query, stretchy mucus, and then a change. Now, Hedi hasn't marked a peak. She's been a very good student because her teacher would have told her that you don't mark a peak unless you experience slippery. And Hedi hasn't experienced slippery, but she has had that changing, developing pattern that we say is part of the criteria for identifying a peak at ovulation. She's had intercourse on day 14 because her teachers told her the sort of things to look out for and the best time to have intercourse. So we don't know whether this is the end of her fertile phase because we don't even know whether she actually ovulated. We can't say for sure in this case. We can see that there's a luteal phase here, what looks like a luteal phase anyway, with another bleed at a reasonable distance, so she could have ovulated. Now, this was an interesting case because this was only the 2nd month of charting. Hedi had just started to see a teacher, and when the teacher saw this chart for the 2nd cycle, she looked at it and she thought, that just doesn't look right. Usually during the fertile phase here, The sensations are increasing as they have done here, but not a great progression, just from dry to wet. They didn't go on to slippery. But what she's seeing is really unusual, thick and oozing, thick and opaque, thick and stretchy. Thick is not what we expect to see at this time of the cycle, because the mucus at this time of the cycle is usually becoming thinner and more fluid and clearer. So the teacher's thinking, this isn't right. So she has her suspicions about what might be going on, but in order to determine whether she's right or not, she asks Heidi to go and get some tests done, some hormone assays done. And this is what comes back. Now, don't be too confused by this. We're going to go through all of this. The purple line that you see there is Heidi's estrogen levels. And they're pretty normal. This is what we expect to see. We see rising estrogens here as the eggs develop. The estrogen gets to a point where it usually triggers a surge of LH, which triggers ovulation, and then it falls and rises again a little bit in the latter half of the cycle. The dotted orange line is her progesterone levels, which are normally low before ovulation, as they are here. They're low, and after ovulation, they rise quite dramatically. That all looks very normal. But here's the day of ovulation. So she did, in fact, ovulate. Even though we couldn't pick a peak, she did ovulate. And notice she ovulated here and she had intercourse the day before, but she didn't get pregnant. You know, it's not compulsory that you get pregnant if you have intercourse near ovulation, but you'd be wondering why not. And the answer lies in this progesterone level. This is an abnormally high pre-ovulatory progesterone. This blue line is where the hormone levels should be. And look at them, they're nearly twice the level that they should be. And this high progesterone level is affecting the mucus so that it's too thick and the sperm can't burrow through it. And it's affecting the quality of the ovulation. So this woman was never going to become pregnant with these high progesterone levels. This black dotted line here is the level that tells us if the progesterone levels go above that line, ovulation has definitely occurred. So we know she's ovulated, but she wasn't going to get pregnant. And this is actually a problem with the adrenal glands. The adrenal glands are producing too much progesterone, and this can be rectified with medication. It's not a huge problem. But this certainly isn't normal for a 33-year-old woman, even a post-pill woman. You shouldn't be seeing those sorts of signs. So again, with a good teacher, this woman wouldn't have picked this up on her own because she wasn't experienced enough. But with a good teacher and a good eye for that detail, this problem was fixed for this woman. Now, the third chart I want to show you is a much more serious problem. Carol was an experienced Billings ovulation method user. She's 33 years old, and in her previous cycle, she noticed that her chart had dramatically changed. So she organised an appointment with her GP and with her teacher to discuss the changes. Now, again, you can see here she's marked 2 peaks. That's the first thing that sticks out as being very, very wrong. You don't have 2 ovulations in one cycle. So what's going on here? Well, bleed here, she knows this is menstruation because she knows she ovulated in the previous cycle. She's got no BIP here in this cycle. That doesn't necessarily matter, but for a cycle this long, she should have. She's got a developing pattern: moist, moist, slippery, wet, slippery, wet, slippery, wet, slippery, clear, wet, slippery, clear, wet, slippery, clear, slippery, developing to dry later in the day, and then dryish the next day. So She thinks, oh, well, that's a bit sluggish. It's not normally as long as that, but okay, I'm getting older. She marks a peak, starts her count to wait those 3 days after the peak. And then she starts getting more symptoms: clear and opaque, slippery plug, clear, opaque, copious, stretchy, slippery, opaque, copious, stretchy, slippery. That just shouldn't happen after ovulation. Not at all. Clear, opaque, stretchy, slight, slippery, dryish. So she thinks, well, maybe this wasn't really an ovulation. Maybe this was the ovulation here. I've had stretchy and slippery. I've gone to dryish. I'll mark a peak here. So she continues to chart. She goes dry again. But then here on day 26, slight, slippery, clear, yellow, stretchy. It's really, really odd. Now, because she was an experienced Billings ovulation method user, and actually she was also a nurse, which I suppose gave her a little bit of an advantage over most of us, but she realised that there was something wrong here. Because she was getting all of this slipperiness, she believed that there was something wrong with the cervix, in the part of the cervix that produces this slippery mucus, which is very, very high up, right at the top of the cervix. She had had a pap smear 6 months before, which had come back fine, no adverse results at all. But she went back to her GP and she asked the GP to repeat the pap smear and to try and take a sample from as high up in that area where these crypts are as could be done. And God bless the GP. I don't know whether it was a he or a she, but God bless them, because they did exactly as this lady asked. And when she got the results, oh, I should have brought these up for you so you could see them more clearly. That was the first stretch of charting. Here's the second stretch of charting, which still wasn't quite right. Was it a peak? Wasn't it a peak? And then if it was, this very short luteal phase. But when those results came back, this woman had adenocarcinoma of the cervix. And there was no question, she had to have a hysterectomy. And she was very lucky because there was no evidence of metastatic cancer. So this woman, due to her own vigilance and her own knowledge about what her body was like, what was normal for her, was able to pick up very clearly that something's very wrong here. This, as I said, was the second cycle that she'd had that was abnormal like this. And the doctor said to her that normally they would never get a sample from that high up in the cervix. It just wasn't normally where they would take a sample. And if they hadn't taken the sample, they would never have found the cancer. Now, we're not suggesting that women can self-diagnose. We're not suggesting that Billings teachers are the font of all knowledge and we know what's causing everything. What we do know is what's normal and what isn't. And so this is a very salient lesson about don't put it off. If you see something you think is abnormal, get medical attention. If it's nothing, you've lost nothing. If it is something, you've gotten onto it early and it can be treated early, and the likelihood is you'll get a better outcome. So they're just 3 very simple examples of different facets of a woman's cycle that, if she knows her body, will be apparent to her, and which will just spark that idea of, I better keep an eye on this. I'll see if this happens again in the next cycle. And if it continues to happen, I'll go and seek medical attention. So that's really the end of my presentation. And I'm wondering whether perhaps there are any more questions that might have come through.
Yes, Lynn, there has been a couple more. So someone asked, during the fertility stage or fertile stage, how often should one be having sex when trying to conceive?
It sounds a bit counterintuitive, but what we advise is once you notice that change from infertility, so a change from the basic BIP to the basic infertile pattern to your first day of change, which tells you your fertility has started, we advise you to wait and don't have sex. Now, I know that sounds like the complete opposite to what you feel you should be doing. But if you wait, you'll be able to see the development of those symptoms. If you start having intercourse every day, you're going to be feeling wet, 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 wet every day because of all of the seminal fluid that you're experiencing. Whereas if you wait and watch for the development of the pattern, when you get to that very wet stage, just bordering on slippery, that's the best time to start having intercourse, and then have intercourse over the time of the peak and for a day or two after the peak, just in case in this cycle, it's one of those cycles where ovulation occurs on the second day past the peak. So don't stop just because you can identify your peak day. Have intercourse for the next couple of days as well.
Okay, thanks, Lynn. There's another question here. What is the immediate effect of taking the emergency contraception pill?
Oh, right. Okay. So what you're doing really is taking, and we're referring to the morning after pill here, is its common name. And what you're really doing is taking a very high dose of synthetic hormones, very similar to what's in the normal contraceptive pill. So a very high dose of estrogen and progesterone, and that causes the lining of the uterus to grow very quickly. That's what normally happens with high levels of estrogen. The endometrium starts to grow. But once you stop taking the pill, so after you've taken your 2 doses and you stop taking the pill, that support for the endometrium drops because you're no longer taking extra hormones. And so that lining will tend to come away. So, and of course, if it comes away, then the pregnancy comes away with it. So that's why a lot of the symptoms that you get normally when you use the morning after pill, they're usually related to high levels of estrogen. They're often the same as women get during the early stages of pregnancy, like morning sickness. You can get nausea, you can feel really lethargic. It's all related to these high levels of estrogen. And then you'll have a very, very heavy bleed because all of that lining will be coming away, and with it the pregnancy. So that's the most immediate effect. Thanks. I hope that's answered the question sufficiently.
Yeah, and someone also asked, is it normal to feel wet right before your period?
It can do, yes. As we saw in that shot of Hedi, it was, where we had the hormone levels shown there on the screen. After ovulation, both estrogen and progesterone levels are high, and they reach their highest point at about a week after ovulation. And then if the body recognises that there's no pregnancy, those hormones gradually start to fall. And they fall until they reach a level where they trigger menstruation. Now, they have those 2 hormones have a counterpoint to one another. The estrogen is what usually makes us feel wet. It's what produces the mucus, causes the cervix to respond. But the progesterone has a drying effect on that mucus, so it dries it up. But at the end of the cycle, you can get one hormone falling a little bit more quickly than the other. They don't necessarily fall uniformly. So you can have the progesterone dropping a little bit earlier than the estrogen, and that leaves behind a little wetness that's not coming from the cervix, it's coming from the vaginal walls, but it leaves this wetness in its wake because the progesterone causes the drying out of anything that leaves the vagina. And when it's not drying it out, you'll notice this wetness that occurs just for a day or so. But when you get to know your cycle, you'll begin to realise it's nothing like the wetness that you experience at ovulation during your fertile phase. It's different altogether. You feel wet, but the look of the discharge is totally different. And once you've seen an ovulation occur, if you've seen your peak, then you know that this can't be another ovulation. This is just that little bit of wetness before the next bleed.
Thanks, Lynn. Someone else asked, does a light or heavy cycle have a correlation to fertility?
That's a good question. It doesn't always, no. Some women will have, very short bleeds, and they don't seem to lose much blood at all. And that doesn't mean they're any less fertile than a woman that loses a lot of blood. The amount of blood really is in proportion to the amount of estrogen we produce. As the eggs are growing and developing, they give off estrogen, and it's the estrogen that causes the lining of the uterus to build up in preparation for a pregnancy. So if you have a lot of estrogen coming from a lot of eggs, then you're going to build up more endometrium. And of course, when that comes away, it's going to be a heavier bleed. If you have fewer eggs, you'll have less estrogen produced, you'll have less growth in the endometrium, and so you'll have a lighter bleed. So it doesn't necessarily relate at all, but it is one of those reasons why women going through perimenopause will often have very heavy bleeds, because they're getting lots of stimulation of the ovaries, they're getting lots of estrogen being produced, but the mechanism of ovulation is faulty. So they're going to get a lot of growth of the endometrium, perhaps without even an ovulation occurring. And then when they bleed, they're going to get a lot of heavy bleeding. So it's related, the amount of blood is related to the amount of growth of the endometrium, not necessarily to the degree of fertility of the woman.
Okay. That's just a follow-up question regarding the morning after pill. Then someone's asking, would taking the morning after pill interfere with the charting process?
It won't interfere with the charting process. I mean, you can keep a chart no matter what's happening. What it interferes with is the resumption of a normal cycle, because it's a bit like if a woman has a miscarriage. 1 minute the body knows it's pregnant and it's producing all of the hormones and going through all the processes it needs to maintain that pregnancy safely, and then very quickly afterwards that pregnancy is lost, whether by miscarriage or by taking the morning after pill, and the body then has to have a readjustment to decide, hang on, what am I supposed to be doing here? I thought I was pregnant. So it may be that a woman, of course, she'll get bleeding and sometimes a lot of spotting when she wouldn't normally do that, simply because of this shedding of the lining. But it's really a matter of when does her fertility resume, and she may have some time before she actually sees a normal ovulation. So that's more the issue, is how long does it take her body to recover from that and get back into a normal cycle. When she does, of course, if she's charting, she'll see that as it happens. That's the benefit. She'll also see if it's not happening. And if it's not happening for a long time, then that's another reason that she should go back and see her doctor.
Thanks, Lynn. A couple of, there's lots of questions. A couple have come up in regard to some of the case studies that you put up during your presentation. I mustn't have been paying full attention. Was one of the ladies' names Carol?
Yes, she was the cancer lady.
So for Carol's case, would it happen gradually over months, or would it show up distinctly within a cycle, is the question.
Look, in this particular case, it was over 2 cycles. The cycle prior to the one I showed you, she'd noticed that things were different, but she thought that might just be a one-off. But when she saw a similar changes in the next cycle, she didn't like the look of that at all. So and I mean, really, when you look at it, that is a very deranged chart. Deranged sounds like a funny word to use, but it's well out of the normal range of what we would expect to see. That's nothing like a normal chart. So that would be ringing alarm bells pretty quickly. It may be that other cancers don't have the same sort of dramatic symptoms as hers does. But it's different for each woman because each woman's chart is unique in any case. And that's why it's really important to know what's normal for you. Your changes may not be the same as Carol's. Hers were that way because the cancer was so high up in the cervix. If another woman's cancer is located in a different place, a different aspect of her symptoms will be different. The point is, they're not what's normal for you. They don't have to be the same as Carol's to be a problem. They just have to be different to what you normally experience and expect to see. That's the clue. And as I said, if you go along and they don't find anything, you've lost nothing.
Great. Someone asked, how common is having an ovulatory, I don't know how to pronounce that. I should know. How common is
an ovulatory cycle?
Cycles at 35.
Okay. Well, again, this gets back to the it all depends situation. You can't make hard and fast rules, but I would think that anovulatory cycles are, well, actually, let's talk about that term for a minute, anovulatory cycles. There really can't be an anovulatory cycle. Every cycle contains an ovulation. What it means, though, really, is that you've had more than one bleed in a cycle. If we go back to, let me just go back here and I'll see if I can, where were we? This one. Don't let me, it's not going to let me do that. I'm going to have to fast forward through all these things for you to get to it. But this is an example. Here we go. So here's a cycle that's got a bleed here at the beginning. We've got a bleed here, and all being well, we're going to have another bleed at the other end. Okay. So that might be over the course of, say, 6 weeks. The woman might have had 3 bleeds. Now, she actually hasn't had 2 cycles. This isn't a cycle, and this isn't a cycle. The whole lot together, including the bleeds, is 1 cycle. So there's really no such thing as an anovulatory cycle. There is bleeding. There's anovular bleeding, not an anovular cycle. And I know that's sort of splitting hairs, but that's another thing women will learn when they, actually, I didn't share my screen then, did I? So nobody could see what I was talking about. I do apologise. The bleed that occurs, the mucus that occurs that doesn't result in ovulation but has a little bleed attached to it is just what we were talking about before. We talked about the lining grows. Now, when the lining's growing, it's only doing what the estrogen's telling it to do. It doesn't know whether there's going to be a pregnancy or not. It's just growing in case. Now, if that ovulation doesn't happen, there's nothing to support that lining and it will come away. and it will come away usually reasonably soon after that little attempt at ovulation. But that's not menstruation. That's an anovular bleed, a bleed without ovulation. And that's occurring within a cycle. It's not the end of the cycle and the start of a new one. It's in the middle or somewhere within the cycle. So we don't get anovular cycles, but we get multiple bleeds within the one cycle, and each bleed will probably be attached to an attempt at ovulation that doesn't succeed. Now, there are times of life when that's normal. Perimenopause is one time. It can be post-pill. Menarche, definitely a young girl who's just starting her cycles, who's not having regular bleeds yet. She'll be having a lot of anovular bleeds. Breastfeeding, when fertility is returning, you'll get anovular bleeds. Now, not all women will, but they're the situations in which we expect to see it as a normal thing. If the woman who's having anovular bleeds, regardless of whether she's 25 or 35, if it's not right for her life stage, if she's not a breastfeeder, if she's not perimenopausal, if she's not post-pill, there's got to be a reason for it. The other situation where it's quite common is with PCOS. Women with PCO have this situation where they're trying to ovulate, but they don't quite get there. And then they drop back into infertility, and then they try again. And each time they try, this lining builds up until eventually it just gets shed, whether they ovulate or not. So you can get these patches of bleeding that aren't related to any ovulations, and that's another sign that it needs investigation. So you've really got to know who this woman is, you know. And if you're not in any of those situations, and this is happening fairly regularly, my advice would be have a talk to your doctor about it. At least start that conversation.
That's great, Lynn. Thank you for answering all those questions.
That's my pleasure.
So shall I wrap up now, or did you want to have any final comment?
I just think, I mean, the beauty of knowing your own body can't be overestimated, I don't think. And learning about charting your fertility, regardless of whether you use the Billings method or some other method, it's really so important. It's like learning a language. Your body's trying to send you messages all the time, but they're in a language that you don't quite understand. You've heard a few, you've read a bit about it, you know a couple of words, but you don't really get the whole picture unless you learn the language properly. And that's all learning a method is. That's all consulting a teacher is. It's just learning to speak the same language as your body is speaking and understanding what it means. And so I can't stress enough how important it is, if you really want to get the best from any method, any natural method at all, you need to consult a teacher, because the teacher, will support you through that learning process so that you don't feel anxious and stressed. That was the point I was going to make about anovular cycles. I'm sure there are thousands, hundreds of thousands, millions of women all around the world at the moment who are having anovular cycles, or stress cycles, we might like to call them, because of COVID. If we'd gone to the Olympic Village 2 weeks ago and asked all of the female athletes whether they were having regular cycles, a lot of them would have said, no, I haven't bled for 2 or 3 months. Now, that for them is normal because they've been in high intensity training preparing for this really important athletic meet or competition. It's normal for them when they're exercising heavily and in full training mode their body's going to react by saying, she's losing weight, she hasn't got enough meat on her bones, she can't carry a baby to term, so we won't even ovulate. It's too dangerous. It's a hangover. It's an old evolutionary hangover from days when you didn't know when hubby was going to be able to bring home the next brontosaurus. So, you know, you could have got a long time between a good meal. So, you know, our body, and that still happens in the animal kingdom. Now, in times of plenty, animals become more fertile than they do in times of drought where there's no food. So our body is this wonderful mechanism that reacts, and all we have to do is learn to understand what those reactions mean and how to cope with them. And the Billings method, for one, is a method that you can use throughout any stage of your reproductive life. You don't have to have regular cycles because you're not trying to predict what's going to happen. You're looking at evidence day by day by day. You're putting a stamp on your chart today that's as a result of you saying, what did I see and feel today? This is what I saw and felt. Is this my BIP? Yes, so I put this stamp on. Is this my BIP? No, it's not. So it could be potentially fertile, so you put a different stamp on your chart. You're not looking ahead, you're looking at today and taking account of what's happening today. So you don't have to worry about next week or next month. You just deal with today. And the rules of the method will see you through that process. The other thing we really should talk about is apps. There are so many apps available in the app stores these days, and just a word of warning, some of them can be great, but I think we have to be aware that any app that tries to predict when we're going to be fertile is dangerous. Because what these little apps do is they ask you to put in details of your last few cycles. What they're doing when you do that is they're calculating the average length of your cycle, and then they're saying, well, if we count back that 2 weeks from menstruation to the previous ovulation, we can see when she's fertile. So if she starts her new cycle today, if we count forward the same number of days as she had in the last few cycles and then count back the 14 days, that's when this woman is going to be fertile. Now, that holds true mostly if you are extremely regular every cycle. I don't think you can say any woman is extremely regular every cycle right through all of her reproductive life. Every woman, no matter how healthy, is occasionally going to have a cycle that's a bit shorter, more likely a bit longer, due to some sort of stress incident. Now, the problem with the apps is they don't know you're going to have a long cycle until you get to the end of it. Then they recalibrate their little predictions. But they can't calibrate it while you're in that long cycle. So the evidence they're giving you about that cycle is flawed from the very beginning. With something like the Billings method, where you're charting your cycle day by day, if you normally have about a 28 to 30-day cycle, you're probably starting your fertile phase somewhere around day 10 to 12. If you get to day 12 and you haven't had any sign of fertility yet, you're still seeing your basic and fertile pattern, then you know this is going to be a long cycle, because you know you're in one of those cycles where the BIP is extending, it's longer than it usually is, therefore ovulation is getting pushed back. And again, you don't have to worry about when is it coming. You just have to say, am I still in my BIP? Yes, then I can use the rule that applies to the BIP. Have I seen a change to potential fertility? Yes, it didn't happen on the 10th, it happened on the 14th. So you're obviously not going to have a 28-day cycle in that cycle. If you're not starting your fertility until the 14th day of your cycle, you're not going to ovulate until somewhere around the 20th day of your cycle, which means you're going to have a 35, 36-day cycle. Once you ovulate, you can always predict when you're going to menstruate but you can't do it the other way around. You can't say, today I'm starting menstruation, therefore I'm going to ovulate here. It doesn't work that way. And that's the only issue with these predictive apps. If you're using a system that's just a way of recording your cycle and they're asking you little questions, and that's great. But if it's trying to tell you when you're fertile, just be a little bit wary, because great and all as it seems, there is that capacity for inaccuracy that's inbuilt into them. And it's just a word of warning. Enough talk from me.
No, I think that's a really important point, because you know, we are flooded with lots of choice these days, and sometimes it's knowing, you know, which one to choose. So I guess for people that are interested in learning more about the Billings ovulation method, would like to have a Billings ovulation method tutor, Billings Life is offering a free, no obligation consultation with one of our accredited Billings ovulation method teachers. So if you want to arrange that, you just need to contact us through our website, which Lynn's just putting it up now. So the one that's billings.life, if you just type that in, that will pop up, and just go to the contact page and put your details in there. We'll get in touch with you to organise that. So as Lynn mentioned, if you're gung-ho and just want to get straight into it, we do recommend having a tutor. It's really important to have a tutor to interpret your chart correctly, because every woman and every couple's fertility is a little bit different. So your tutor will help you interpret that. So yeah, so please feel free. For people that are overseas, I know that there are some people on the call this evening. You can go to the Womb International website. I'm not sure if we have it up there, but I can pop it in the chat. It's just womb.international.org. And if you go to the Global Outreach little tab, you'll see all the contacts for Billings centres right across the world. So that's a great resource if you want to get in touch with a Billings tutor in your country. Obviously, we do now have tutors available online as well as in person where we can at the moment. But yes, a lot of our consultations are happening now online, and you can do your chart online through the Billings app or Fertility Pinpoint, which you can see on your screen there. That's an online charting tool, which is really great. You can share that with your tutor, and you can message through that as well. So yeah, finally, just would like to say thanks to Lynn. That was a really great presentation, and I think it was amazing to see so many different variants of women's cycles, and it's something that I'm sure we can all relate to, because we all have our own individual situation. It's great to know that there is a method that can cater to everyone and in every stage. So thank you, Lynn, so much for showing us that. And thank you to all of you for participating. It's great to be part of Natural Fertility Awareness Week. We hope you're a little bit more aware. I'm sure you are. And for all those great questions as well. I certainly learnt a lot from that too. So thank you. We will have an evaluation form that we'll email you in the next couple of days, if you'd be kind to spend a couple of minutes to fill that out, because that will help us to plan future webinars and events like this. So look out for that. We also have a great shop on our website, the billings.life website. So there's free resources you can download there, as well as books that you can order and other materials. So if you get a chance, have a look there. So I think that probably covers everything up. So thanks again, and we hope that someone's asked, is there some way we can access this presentation? I do believe we did record it this evening, so that's something that I can send out in the email to everyone if you'd like the recording of this, because I know there's a lot of information there, so it might be something to digest over time. We also do have a YouTube channel that's got quite a good information clip on the Billings ovulation method, so that's worth having a look at as well. Thanks again. And yeah, thanks, Lynn. That was really good.
You're welcome. Bye, everyone.